Welcome. Tonight we're going to walk through dizziness in the emergency department with a clear, practical frame you can use tomorrow. This is educational only. Follow your local policies, stroke pathways, and the ETG. We'll keep the pace calm, but the content is all business. No fluff, no pseudo-wisdom, just a clean approach you can run when you're tired, busy, or both. When a patient says dizzy, treat it as a symptom label, not a diagnosis. Clarify what they mean without getting stuck in semantics. 2 questions do most of the heavy lifting. First, does the room feel like it's spinning? If yes, think vestibular. If no, consider presyncope, disequilibrium, visual problems, medication effects, or functional causes. Second, is the symptom continuous right now, or does it come in episodes? That single split, continuous versus episodic, drives most of your next decisions. If it's continuous for hours to days, you're likely in the territory of an acute vestibular syndrome, abrupt onset, persistent vertigo or dizziness, nausea and vomiting, intolerance of head movement, spontaneous nystagmus, and unsteady gait. The core differential is vestibular neuritis, or labyrinthitis, versus posterior circulation stroke. If it's episodic and triggered by position, rolling in bed, looking up, lying back, think benign paroxysmal positional vertigo, usually posterior canal, sometimes horizontal. If it's episodic and spontaneous, arriving without a clear trigger and lasting minutes to hours, think vestibular migraine, Meniere's disease if there's fluctuating hearing, or transient ischemic mechanisms depending on the story and risk. Keep 2 other buckets nearby that aren't vertigo: presyncope, driven by orthostatics or arrhythmia, and imbalance or visual disturbance from neuropathy, Parkinsonism, new lenses, or persistent postural perceptual dizziness. Red flags should quietly sharpen your index of suspicion. New focal neurological deficits, such as dysarthria, diplopia, dysphagia, hemiparesis, hemisensory changes, or severe truncal ataxia, push you to think central. Direction-changing gaze-evoked nystagmus, vertical nystagmus, or a skew deviation are central ocular signs until proven otherwise. High vascular risk, atrial fibrillation, anticoagulation, dissection mechanisms, recent stroke or TIA raises the stakes. A sudden, unusual headache or neck pain with neurological features matters. An inability to sit or stand without support in the context of an acute vestibular syndrome is a strong central clue. Hearing loss plus neurological signs should make you consider AICA territory stroke, and severe persistent vomiting with dehydration and acute kidney injury risk may determine disposition even if the diagnosis is peripheral. Start with basics before chasing nuance. Check vitals, including a proper orthostatic blood pressure and heart rate after a couple of minutes upright. Check glucose. Run a quick cardiorespiratory screen. Listen, look at the rhythm, make sure oxygenation is adequate, and don't miss the simple things. Then sit at eye level and watch the eyes before you touch the head. In primary gaze, look for spontaneous nystagmus. With horizontal gaze left and right, notice whether nystagmus stays unidirectional or changes direction with gaze. Direction changing or vertical components point central. Purely torsional patterns without typical positional triggers should also raise an eyebrow. If the patient is in a true continuous acute vestibular syndrome and you've trained for it, the hints battery can be useful, but only in that context, and only if you are comfortable with it. The head impulse test is abnormal, with a corrective saccade, when there's a peripheral vestibular hypofunction. Paradoxically, a normal head impulse in a truly vertiginous patient with spontaneous nystagmus is worrisome for central causes. Nystagmus that is unidirectional and follows Alexander's law favors peripheral. direction changing or vertical points central. A test of skew with vertical realignment suggests central pathology. Add hearing to make it hints plus. New unilateral hearing loss in an acute vestibular syndrome can herald an AICA stroke. Remember the caveat. HINTS outperforms early CT and even early MRI for posterior fossa stroke in expert hands. If you're not confident or the exam is equivocal, do not overcall peripheral disease. Err on the side of stroke pathways and appropriate imaging. Gait and stance matter. Severe truncal ataxia, needing assistance to sit or unable to stand, is not typical of a simple peripheral lesion and should push you towards central workup. Then do a focused cranial nerve and cerebellar survey. Saccades and pursuits, finger nose, heel shin, rapid alternating movements, facial symmetry, palate elevation, tongue, and speech. Don't forget the ears. A quick otoscopic look can reveal cerumen or otitis. A finger rub or simple tuning fork screen picks up gross unilateral loss, and a history of fluctuating hearing, tinnitus, or oral fullness nudges you toward Meniere disease. For positional symptoms, save Dix-Hallpike for when the history supports positional triggers. You're looking for reproduction of vertigo and an upbeating torsional nystagmus toward the undermost ear with posterior canal involvement. If the features are more horizontal, use a supine head roll test and observe for geotropic or apogeotropic horizontal nystagmus to guide the canal diagnosis. Imaging decisions should be deliberate. A normal CT does not exclude posterior circulation stroke. The posterior fossa is CT unfriendly. Use CT when you need to exclude hemorrhage or other emergent CT visible pathologies, but don't let a normal CT anchor you. MRI with diffusion-weighted sequences is preferred for posterior circulation stroke, with the important asterisk that very early scans can be false negative in the first day. If the story remains concerning, escalation and repeat imaging may be required. Add CT angiography of the head and neck when you suspect dissection or large vessel disease. When HINTS is central or equivocal, or when red flags are present, treat it as stroke until proven otherwise and follow your local pathway. At the bedside, there are moves that change the trajectory. For classic posterior canal, BPPV, brief, triggered vertigo with a positive Dix-Hallpike and typical upbeating torsional nystagmus, a normal neurological exam, and symptom-free intervals, perform a canalith repositioning maneuver, such as the Epley. If horizontal canal signs are present, shift to a supine roll test and consider the barbecue, or Lempert, maneuver. Warn about transient nausea and have emesis bags handy. Document which ear and canal you treated and the immediate response. For vestibular neuritis, think in phases. Support the first 24 to 48 hours with vestibular suppressants and antiemetics if needed, then taper. Prolonged use slows central compensation. If your local guideline supports it and there are no contraindications, a short course of oral steroids within the first 72 hours may be appropriate. Follow the local policy rather than habit. Early vestibular physiotherapy improves recovery. Say it aloud and write it down. Labyrinthitis looks like neuritis with the addition of hearing loss and needs audiology follow-up. Disposition flows from risk, function, and the diagnosis you can define. Midwives will observe patients with suspected stroke, those with equivocal or central leaning hints, those with severe ataxia who cannot mobilize safely, intractable vomiting, dehydration, or an uncertain diagnosis with concerning comorbidity before support. Discharge is reasonable for classic BPPV after effective repositioning, should give us ambulatory Posterior circulation stroke is often an acute vestibular syndrome in an older patient with vascular risk, abrupt onset, possibly neck pain or dissection risk. The exam may show a normal head impulse, direction-changing nystagmus, skew deviation, severe truncal ataxia, or new focal deficits. That story belongs on a stroke pathway. Pre-syncope mimics come with orthostatic hypotension, dysrhythmia, anemia, hypoglycemia, sepsis, or medications. The clue is the language: lightheaded, graying out, worse upright, without nystagmus, and with a normal oculomotor exam. Orthostatic vitals and ECG are high yield. Pick labs to confirm your suspected systemic cause rather than ordering a panel by reflex. Avoid a few common pitfalls. A normal CT is not reassuring in the posterior fossa. You already know that, but say it to yourself in real time when colleagues are anchoring. Early MR diffusion can be falsely negative. If the exam and story don't line up, escalate rather than discharge on a scan result. Don't order every lab because you can. Pick the tests that answer the question you actually have. Always get an ECG when pre-syncope is on the table. It's cheap, fast, and changes plans. Write the note you would want to find at 3 in the morning. Label the phenotype up front. For example, acute vestibular syndrome, continuous vertigo 8 hours, nausea and vomiting, spontaneous left beating nystagmus. Then record the core exam. Head impulse abnormal to the right, nystagmus unidirectional, no skew, no focal neurological deficits, ambulant with 1 assist. Or, if central features are present, head impulse normal bilaterally, direction changing nystagmus, positive skew, severe truncal ataxia, central concern. Document positional testing. If you did it, Dix-Hallpike right positive with upbeating torsional nystagmus, Epley performed twice with improvement. Then your decision and safety net. No red flags, oral intake adequate, reliable support. Return for new neurological deficit, intractable vomiting, inability to mobilize, new hearing loss, or if symptoms persist or worsen beyond 72 hours. Vestibular physiotherapy referral per local pathway. That level of clarity lets night you sleep. If you're sending someone home with neuritis, say out loud that vestibular suppressants, if used, are for the first day or two only, and that movement is part of recovery. If you've treated BPPV, tell them what you did, which ear and canal, what to expect tonight, and when to return. If stroke remains possible, don't discharge on the comfort of a normal CT or an equivocal exam. Use your pathway and your judgment. Before we close, a short checklist that fits in a pocket. Timing, continuous versus episodic. Triggers, positional or spontaneous. Targeted exam, eyes in primary and with gaze. Hints in trained hands only, skew, hearing, and gait. Image the right people, not the comfortable ones. Treat the thing you can at the bedside. Reposition when it's BPPV, support and rehabilitate when it's neuritis. Escalate when it's central. This has been a deliberate, quiet walk through dizziness for the emergency department. It's educational, not prescriptive. Follow your local policies and the ETG. If you're listening on the way to sleep, let the edges blur a little now. You've put the structure